So in the background of HIV, differentials can be a single space occupying lesion that can be bacterial, fungal brain abscess, tuberculous brain abscess. It can be primary CNS lymphoma, tuberculoma, toxoplasma, and neurocystocercosis. Although usually they present as multiple lesions, but can be single as well. Cryptococoma. And in case of multiple space occupying lesions, toxoplasma, tuberculomas, metastatic brain lesions, neurocystocercosis, and cryptococomas. In diffuse brain disease, topmost is progressive multifocal leukoencephalopathy and HIV-associated encephalopathy. Both are very close differentials. Other causes of diffuse brain disease can be viral encephalitis, can be any virus like CMV, HSV, or West Nile. Neurosyphilis can also present like this. In case of meningitis, it can be bacterial, fungal, tuberculous, cryptococcal, or can be syphilitic meningitis. So our first case is a known patient of HIV since October 2021 and was on ARV since then. His initial CD4 count was 89. Previously, he was treated as a presumed case of pulmonary tuberculosis for 6 months by a local doctor. He presented in April 2022 with bilateral lower limb weakness to us. His MRI brain was already done that showed a well-defined oval shape, abnormal signal intensity, peripherally enhancing mass lesion just lateral to fourth ventricle in left cerebellar hemisphere with mild vasogenic perilesional edema extending up to the left midbrain. So at that time, we offered him a brain biopsy, but it could not be done because of non-affordability, and the patient became DOR. So no diagnostic procedure was done. In July 2022, he became unconscious and was taken to Punjab Institute of Neurological Sciences, where he was found to have an acute obstructed hydrocephalus for which VP shunt was inserted, and he was then referred to ID clinic at PIMS. On receiving, the patient's GCS was 7/15. He had upgoing planters and right grace preference, and the rest of the systemic examination was normal as GCS was low, so other neurological examination could not be elicited. His initial lab workup was normal, except for the X-ray chest that showed consolidation in the right lower zone, for which we treated him as an hospital-acquired pneumonia. His CD4 count was 89. His echo was normal, and his toxoplasma serology was negative. His repeat MRI brain was done, and MRS was also done, and neurosurgical team was approached for possible biopsy and aspiration. And now I over this to Dr. Shahabuddin, who will explain.
So as Madam Sana explained, the patient underwent MRI. Do we have a little bit of idea about what the images are being shown right now? Can anybody participate and tell us what this image is, what this image is, and what this image shows? You guys can unmute your mic and tell me which one is this sequence, which one is this sequence, and which one is this sequence. Since we're short of time, Gigi. Somebody is answering. जी कोई कुछ बोल रहा था.
The first one is T1, then T2, then flare.
All right. So what the first sequence is the flare, the second sequence is T2, and the third sequence is T1. How do you differentiate between T1 and flare is on the gray-white differentiation. On T1, the gray matter, the peripheral cortex, which is the gray matter of the brain, which I'm indicating with my arrow point, if all can see, appears gray, and the white matter appears relatively whiter than gray matter. All right. And on the flare sequence, this relationship is inverse. The gray matter, the outer cortex here, appears whiter than the white matter. Hence, this sequence is flare, and this sequence is T1. So we have three sequences, the flare, the first one is the flare, and the second one is T2, and the third one is T1 sequence, axial sections, on which there is this lesion in the left side of the brain in the chordothalamic groove, we can say, in the left cerebellopontine angle in the left cerebellar hemisphere, which appears heterogeneously hyperintense on flare. And then it appears hyperintense. By hyperintense, what I mean is bright on T2. The whole lesion is bright on T2. And if we see closely, there is a hypointense rim all around it. There is a thin hypointense rim all around it, and the same lesion appears hypointense on T1 image. Then we have more images of the same patient. Can anybody now explain what is this image, what is this image, and what is this image? Anybody? This is the T2 coronal image of the same patient. These were the axial images. This is the coronal section of T2 MRI brain. And then we have coronal post-contrast T1 image. And then we have sagittal post-contrast T1 image. And what we see on the post-contrast images is that this lesion is showing smooth, thin peripheral rim enhancement. In other words, we can also say this lesion is showing ring enhancement on post-contrast images. So can anybody explain me the differentials of ring enhancing lesions? And it's very important with infectious diseases as well. कोई बता सकता है differentials ring enhancing lesions के?
And if multiple then neurocysticercosis, this also comes to the differential diagnosis.
थोड़ा सा, can you speak a little bit louder? मुझे आवाज थोड़ी सी कम आ रही है.
Tuberculomas, number first, abscesses, or
जी.
diagnosis, and sometimes
जी.
if multiple then neurocysticercosis is also.
Neurocysticercosis can also present with peripheral enhancement. Then we have toxoplasmosis. It can also present with peripheral enhancement. Then all those immunocompromised patients who have HIV can also develop lymphoma in the brain, and the lymphoma in the brain in immunocompromised patients can also show peripheral enhancement. Other than this, there are many other lesions, including glioblastoma and neoplastic lesions, metastatic disease, which can show peripheral enhancement. We'll not get into that since our topic for today is infectious diseases. All right, so I'll move on quickly. Then we have diffusion weighted image and the ADC sequence. The same lesion is showing a hyperintense signal on the diffusion weighted image, and on the corresponding ADC map, this lesion is showing hypointense or dark signal. So this phenomenon is called diffusion restriction. So this lesion is showing diffusion restriction on MRI, which means it is appearing hyperintense on DWI and hypointense on ADC sequence. We also did the MRS, the MR spectroscopy of this patient. इसको थोड़ा सा जल्दी में मैं थोड़ा सा डिटेल में भी explain करने की कोशिश करूँगा, since this is an important topic. MRS works on the basic principle of the metabolic activity of the tissue. ठीक है, इसमें डिफरेंट मेटाबोलाइट्स जो होते हैं टिश्यूज के, उसके जो है वो एक्टिविटी को जो है वो हम डिटेक्ट करने के लिए MRS करते हैं, टू डिफरेंशिएट बिटवीन बेनाइन एंड मैलिग्नेंट लीजन्स, टू डिफरेंशिएट बिटवीन इन्फेक्शियस एंड नॉन इन्फेक्शियस लीजन्स. सो we have this baseline जिसको हम parts per million में denote करते हैं. This is 1 part per million, this is 2 part per million, this is 3 parts per million, and then there we have 4 parts per million. और इस पे हमें different जो है amplitude या peaks मिल रही हैं different metabolites की. जैसे typically जो lipid lactate metabolite को peak जो आता है वो आता है 1.3 parts per million पे. Then we have the choline creatine peaks which occur at 3 and 3.2 parts per million. So what this lesion, the MRS, the MR spectroscopy was applied to the periphery of this lesion, and it shows significantly elevated lipid lactate peak. ये जो आपको peak नजर आ रहा है यहाँ पे 1.3 parts per million पे, this is the lipid lactate peak. So all these, to sum up, all these MRI and MR spectroscopy findings favor in acute infective disease process, infective lesion, and rest I'll hand over to Madam Sana, and she'll tell us the diagnosis of this patient.
So we requested neurosurgical team for the aspiration of brain lesion, and that was done, and tissue samples were sent for bacterial, fungal, and other microbiological studies. 10 ml of frank pus was also drained from the sample that from the lesion that was sent for the microbiology studies. So what can be the possible differentials in this case? So culture results came one by one. So fungal and bacterial CS were negative. AFB culture was awaited. And histopathology showed areas of necrotizing granulomatous inflammation. Although ZN stain was negative, JMS stain and was also negative, and there was no sign of any malignancy. So further lab results showed AFB smear 2+ positive, and also the gene expert for MTB was also positive, although RIF resistance was not detected. So final diagnosis was drug sensitive tuberculous brain lesion. So he was started on first line ATT and steroids. He was also started on an extra dose of DTG, as he was already on ARVs first line. His conscious level improved from 9 to 13 in weeks time. He was discharged to home and he was called up for follow-up, which he did after 2 months, and he was fully conscious and was able to communicate with us. So this was the first case. Now I will continue with the second case. We had a patient, 48-year-old male, who is the resident of Rawalpindi and is shopkeeper by profession. He was on ATT for last 2 months for pulmonary tuberculosis. He was found to be HIV positive in a local clinic during screening. He presented to ID clinic with fever, altered sensorium, and generalized body stiffness for 1 week. So on examination, he was emaciated, sick looking. He was febrile with the temperature of up to 101, and the rest of the vital signs were normal. His GCS was 9/15, and he had generalized body rigidities, although there were no cranial nerve palsies and there were no signs of any meningeal irritation. So his baseline investigations were all normal, except the ALT was 66. His hepatitis B and C were negative. His VDRL was also negative. His CD4 count was 34. His toxoplasma IgG was positive with the titers of 250. So his MRI brain was done in late August 2022. Dr. Shahab will explain.
So we once again have the MRI images of a different patient, the second case. And all these 3 images are the T2 axial images. In the first image, I can see this lesion, which appears iso to slightly hyperintense on T2 with internal hypointense signals. Then we have multiple areas of vasogenic edema in bilateral centrum semi-ovale. And then again, there is this demonstration of this lesion in the left temporal lobe with vasogenic edema. Same patient, this is the T1, this is flare, this is flare. Again, repeating the point, this is T1. Why? Because the gray matter appears gray and the white matter appears relatively whiter than gray. And this is flare because the gray matter appears whiter and the white matter appears gray. So same patient with the lesion in the left thalamus appearing hypointense, and then we have multiple areas of vasogenic edema and bilateral centrum semi-ovale. So what could be the possible difference? There are multiple lesions on T2, then on T1 and on flare. We don't have post-contrast images of this patient. So what could be the possible differentials? Madam Sana will continue, and what was the final diagnosis she will inshallah reveal.
So his brain biopsy was also done by neurosurgical team in on 30th August 2022, and his sample was sent for histopathology, bacterial and fungal CS, and also for tuberculosis studies. So the results, bacterial and fungal CS came to be negative, and tuberculosis studies also came to be negative. His histopathology showed septate hyphae. This is the HNE stain for septate hyphae. You can see the septa. So this is actually the colony morphology, the early colony morphology, and a few days later. Lacto Yes, these are the white mycelia. So we performed lactophenol cotton blue stain on these colonies, and we got this picture showing mycelia and the aspergillum and conidiophore and different conidia. The final fungal culture report came, and it was actually Aspergillus nidulans. So what is Aspergillus nidulans? Aspergillus species actually are ubiquitous environmental molds. They cause invasive disease in quantitative and qualitative neutrophilic defects patients. And CNS aspergillosis is only 10 to 20%. Most common is Aspergillus fumigatus. Aspergillus nidulans is rare, although it is found in patients of chronic granulomatous disease, especially in lungs. The nidulans is typically resistant to echinocandins, and there we found only 3 case reports of Aspergillus nidulans causing the brain abscess. One is in a 52-year-old woman in Beijing. She had a right temporal lobe abscess, and another 65-year-old male with AML with left and right frontal lobe brain abscess, and one 14-year-old immunocompetent child, 14 months, sorry, immunocompetent male child from India having the brain abscess. So before patient had a biopsy, we started him Septron empirically for toxoplasma, as patient has toxoplasma IgG was positive. Then when initial report of microbiology came that showed septate hyphae, so we started him, or we did not know that which kind of mold it is. It is a black mold or Aspergillus. So we started him on amphotericin B 1 milligram per kg per day for 2 weeks. And then final culture report came and it showed Aspergillus nidulans. So we started him on voriconazole. The patient became conscious. The GCS improved from 9 to almost 15 by 15. He started taking orally, and we followed the voriconazole level that were adequate. So patient was discharged on voriconazole. He came for the follow-up after frequently after 15 months, and then after 2 months, he has already returned to his job, and his follow-up MRI that was done after 2 months showed decrease in the size of the lesions, interval decrease. Then the case 3. A 30-year-old male, he was referred from a hospital in a periphery, admitted there with the complaints of dysphagia for 12 days, weakness of the right half of the body for 2 days, and unconsciousness for a few hours, and undocumented fever. There was no history of any fits. His working diagnosis of meningitis and encephalitis was made, and his initial brain imaging, that was CT scan, was done, and his HIV screening was also done. That came to be positive, and then he was referred to ID PIMS. On examination or receiving, he had a GCS of 9 by 15. His power on the right side was 1 by 5, power on the left side by 3 by 5, although could not be elicited completely because he had not a good GCS. So his planters was equivocal, bilateral. He did not have any sign of meningeal irritation and no cranial nerve palsies. His baseline investigations were all normal. His CD4 count was 79. His X-ray and echo was also normal. His toxoplasma IgG was positive with the titers of 250. So we also sent his VDRL, TPHA, and FTKBS that all came to be positive. And so we performed CSF VDRL that was negative. So we did his initial brain imaging MRI.
Now, this was quite an interesting case. What we see on MRI is T1 image. First, we have T1, we have T2, and then we have flare axial images. So what we see in this patient is that there are poorly defined areas of hyperintensity on T2 and flare. I don't know if you guys can appreciate it. The subtle hyperintensities in the periphery of the brain in around the gray and white junction, bilaterally on this side as well, and on this side as well. Then in the lower sections also we can appreciate hyperintensities in the gray white metal junction peripherally. and on T2 as well. What is interesting to note in this case is that there is no associated mass effect. Then we have coronal images of the same patient. Apart from these deep white matter abnormal signals in bilateral hemispheres, we have hyperintense signals in the bilateral basal ganglia and in the thalamus on the left side. And this is the post-contrast T1 coronal image. And there is no enhancement whatsoever of the lesions that are seen in bilateral basal ganglia and the left thalamus. And we don't see any enhancement of the peripheral lesions in the deep white matter. The important thing here is to see very closely that the gray matter is relatively spared, which I am denoting with my arrow point. All this gray matter at the periphery is spared, whereas the white matter just below it, the deep white matter, we also call this structure the subcortical U fibers, that is involved, that has abnormal signal, which appears hyperintense on T2. We see the same pattern here on the left side as well. The gray matter is relatively spared, and then we have hyperintensities within the deep white matter. And there is no enhancement of these lesions. There is no mass effect, no midline shift, no perilesional vasogenic edema whatsoever. So these you have to keep these things in mind when the final diagnosis of this case is revealed, because that entity does not cause any mass effect, or there is no significant midline shift associated with that pathogen. So over to Madam Sana. Partially, but the major portion, the major part of the brain involved is the deep white matter. Very few, typically radiologically speaking, the gray matter in this disease should not be involved. It is the deep white matter which is ideally involved in this disease. So it is relative. We can say this is relatively atypical, because somewhere there is subtle hyperintensity in the gray matter as well, but predominant pattern of involvement is the deep white matter or the subcortical white matter without any enhancement and without any significant mass effect. All right. So over to Madam Sana.
Can anybody relate the possible differentials in this case? Diffuse brain disease, which is predominantly involving the gray matter, the white matter, but a few areas of gray matter as well.
Can anybody participate? Very nice.
So somebody said JC virus, PML. Very right. So we proceed with the case. So we did initial CSF examination in this case, which showed WBC count of 12 cells per microliter and predominantly lymphocytic 90%. He had a CSF glucose of 38.2, protein 86.3, and blood sugar at that time was 120. So his India ink stain was negative. CSF bacterial and fungal culture came to be negative, and his AFB smear expert was also negative. So we did not had any clue. So we started him empirical treatment. We empirically treated him for herpes simplex and encephalitis with acyclovir for 10 days. And then also we started treatment of toxoplasma encephalitis cerebritis after discussion with our neurosurgery team, radiology, and microbiology. And we also treated him for neurosyphilis for 10 days, but there was no clinical improvement in this case. So after, yes, biopsy could not be done at that time because the patient had diffuse and neurosurgical team refused to take any tissue biopsy, any aspiration, because there was no representative. They said that we do not, yes, it was deep as well, and they cannot perform the tissue biopsy from the representative area. So after 20 days, the patient started showing worsening in the GCS. So we planned to have another imaging done in this patient. MRI was repeated that showed progression of similar lesions to different cortical areas and brainstem as well. So we started him on IV steroid to treat iris. His repeat brain imaging.
Now let's go back for a second. Let's first see these images and keep them in mind. These are the initial images of the patient. He's not improving clinically, and the MR was repeated. And now we see these images. This is flare, this is T2, this is T1. This is T2 coronal image, and this is T1, again with contrast. So what do you guys think? Has the disease progressed? Do you see any signs of progression of the disease? Can anybody tell me? And how and why? कोई बता सकता है थोड़ा इन findings को कि if the disease has progressed, and are there more areas involved now? Can anybody read the MRI?
Yes, the disease has progressed.
How do you say that, madam?
I can see that there is hyperintensities along the capsuloganglionic region and in the occipital region, left occipital
Which was
lobe.
not previously seen. The
Yes.
lesion, the area in the occipital lobe on the left side was not previously involved, if we go back.
Yes,
Right?
it was not
There,
involved.
yeah. And what else?
Capsuloganglionic region, I can
The
appreciate.
capsuloganglionic region, right? So if we see there is diffuse progression of the disease, right? So now there is chiral swelling. Again, repeating my point, this eventually turned out to be a case of PML. By now we have all understood this, but this is not the typical presentation of PML, because typically, radiologically speaking, based on the imaging findings, the gray matter should ideally be spared in PML, and it is the white matter involvement. So we now see there is progression of the white matter involvement, and now there is gray matter involvement as well. We can see the chiral swelling and sulcal effacement, and the gray matter also shows hyperintense signals here also. And this is again the coronal T2 image showing predominant involvement of the white matter, the deep white matter, the subcortical U fibers, with some involvement of the gray matter as well. Typically, PML also does not involve the capsuloganglionic region, but this patient did have the lesions here as well. And again, showing no enhancement whatsoever on post-contrast images T1. These lesions do not show any enhancement. The area of the left occipital lobe does not show any involvement. What is important to note here is that this patient is not showing any brain signs of edema or mass effect or any midline shift, which is a typical radiological finding of this entity. Over to Madam Sana.
So after negotiation with the neurosurgical team, because the patient stayed with us for almost 4 months, so we wanted to reach some kind of diagnosis. We requested them to take a biopsy from any representative area in the brain. So they took the biopsy. We sent that for bacterial fungal culture and also for tuberculosis studies. We also did send it for histopathology. His rest of the cultures, bacterial, fungal, and tuberculosis, initial tuberculosis studies came to be negative. His histopathology showed extensive lymphohistocystic reaction, the histological picture that suggested the viral encephalitis. So we also sent the tissue sample and the CSF for viruses that included HSV, CMV, JC virus, HIV, and West Nile virus. So final diagnosis was JC virus came to be positive with multiple copies in CSF and also many copies in brain tissue. So although the case is not typical of PML because it involved gray matter as of the white matter, and the lesion disseminated to the whole brain in just a period of 20 days. So we diagnosed this case as PML iris because JC virus is not known of causing encephalitis. His HIV RNA was also found in the CSF and brain tissue as well with the copies. So we treated again the patient as a case of PML iris, and we gave him pulse therapy of methylprednisolone 1 gram per day for 3 days. And also we started him mirtazapine 45 milligram at night along with the anti-seizure drugs because patient had a seizure activity. His conscious level improved slightly along with increased movement of the limbs and the return of the sleep and wake cycle following 1 week after the start of the therapy. So this, we all know that we treat iris with the pulse therapy in PML, but we initiated this patient with mirtazapine. We found some evidence in the literature. So we started it on trial basis. Mirtazapine has a promising role in PML and specifically in natalizumab associated PML, but we did not have any other option. So mirtazapine is known to reduce the cell entry and JC virus replication. So we started this mirtazapine on trial basis. This is the link of the literature. The case 4 is a case of a 36-year-old male who presented with complaints of difficulty in walking and irrelevant talk for 3 days. 1 week before, he had an episode of loss of consciousness that was spontaneously recovered. There was no history of any fits or weakness of any part of the body. He is an IV drug user and has a history to travel to Dubai. On examination, patient initially had slight gait ataxia and was confused, although he was obeying simple commands. He did not have any focal neurological deficit or did not have any nerve palsies or any signs of meningeal irritation. The patient conscious level dipped on 3rd day of admission. Meanwhile, we arranged for his biopsy and aspiration. His baseline investigations were all normal, but his echographic study showed an ejection fraction of 40% with a mural apical clot and mild tricuspid regurgitation. Although there was no vegetation seen, any kind of vegetation seen, and his transesophageal echography could not be done because of his low GCS. His CD4 count was 34. His 2 set of blood cultures were negative. So his MRI brain was performed.
All right. What is this sequence? ये कौन सा sequence है? This is T1. And
T1.
why? Because the CSF in the ventricles is low. Plus there is the gray matter in the periphery appears gray and the white matter centrally appears white. And which one is this sequence?
T2.
This is T2. This is clearly T2 because the CSF is hyperintense. And which one is this sequence?
DW.
Flare.
This is flare because the gray matter at the periphery appears whiter than the white matter centrally. All right. Can everybody see that? Can everybody appreciate that?
Yes.
So can anybody explain me the findings in this case also?
We can see an irregular, ill-defined area in the left periventricular region and left capsuloganglionic region.
Absolutely.
Slightly hypertense on T2 flare, and it is slightly heterogeneously hyperintense on T1 as well.
Very well done, madam. So we see this lesion in the left capsuloganglionic region involving the basal ganglia as well as the thalamus in the left periventricular lesion, which appears heterogeneously hypointense on T1. And
Yes.
the lesion actually is this,
Okay.
right? And then there is involvement of the basal ganglia and the thalamus as well. And all this white signal around it is the vasogenic edema that this lesion is causing. So on T2, it appears iso to slightly hypointense with surrounding intense hyperintense vasogenic edema. We see the similar signals on flare as on T2. The lesion appears iso to slightly hypointense, and then there is significant vasogenic edema involving the left capsuloganglionic region.
And it is causing midline shift slightly.
And now in this case, it is causing effacement of the left lateral ventricle and mild midline shift, which is contrary to the case we saw previously. Now, can anybody explain these images? We have time, right? Yeah. Can anybody explain? This is the same patient. The disease process is not just confined to this area.
Yes, it has involved the medulla, midbrain.
Yeah, there's involvement of the gray white junction as well. And then there is involvement of the brain stem as well. The midbrain, the pons is also involved. And then we see the hyperintense signal at the periphery, the gray white matter junction. All right. And then we see hyperintense signal here. And this is the same lesion that we saw on the axial images. And this is flare coronal image, and this again is flare coronal image. This showing the periventricular region, and this predominantly showing the brainstem along with the areas in the periphery of the brain. Now this again is the MR spectroscopy. Now this was done to actually differentiate between if this process is infective or malignant disease process. So what do we see here?
Choline peak.
The region of interest was applied to the lesion in the periventricular region on the left side, and this is the image pattern. We see the choline peak at 3.2 parts per million, then we have creatine peak at 3 parts per million, then we have NAA peak at approximately 2 parts per million, and then there is subtle lipid lactate peak at 1.3 parts per million. Typically, the choline peak is typically seen in malignant lesions. Having said that, the tissue that is necrotic typically demonstrates the choline peak. We usually, as radiologists, I myself associate choline peak with the malignant process, but not all malignant diseases show choline peak, and not all benign diseases have absent choline peak. There are benign lesions also which can show choline peak, especially those which have a lot of necrosis in them. But what is important to note here is the reduced NAA peak. Typically, in a normal brain tissue, the tallest peak among all these peaks is the NAA peak, which has reduced here, which means there is a certain disease process going on. Because in a normal brain tissue, the tallest peak that we see on MR spectroscopy is the NAA, N-acetyl aspartate peak, and we do not typically see choline peaks. We do not see typically creatine peaks. We typically see NA peak, and the normal tissue also does not resonate with the lipid lactate peak. So what this lesion showed was the choline peak. There is certain rise in the creatine peak as well. There is reduced NAA peak, and there is some peak of the lipid lactate. So over to Madam Sana again.
So his lesion was deep at the basal ganglia level, and brain biopsy was very risky. We somehow convinced neurosurgery team to do the neurobiopsy, the brain biopsy, and they did it under high risk consent. His aspiration or biopsy of the sample was done, and it was sent for bacterial fungal cultures and also other microbiological studies, and also for the histopathology. So what can be the differential in this case?
CNS lymphoma.
Yes, we need to ask. Dr. Shahabuddin is saying that we need to ask differentials in this case.
Since we have discussed so many cases by now, what would be the possible differential? Can anybody tell us a differential?
You can write in the chat box as well.
ऐसे बता भी सकते हैं, chat box पे भी लिख सकते हैं. Somebody said lymphoma. Lymphoma was quite a differential, but typically, yes, एक तो MRF पे भी जो है वो choline peak show कर रहा था ना, तो वो भी चीज lymphoma है. What is not going in favor of lymphoma is the multiplicity of lesions. Typically, lymphoma is a single lesion, or even if there are multiple lesions, they are more in the periventricular lesion. But in this case, we also saw some lesions in the periphery of the brain, in the gray white matter junction, which is not a typical feature of lymphoma. What could be the other differentials in this case?
I think we have already so many differential of the similar cases. So The histopathology showed meningoglial tissue chronic inflammation and inflammatory infiltrates that comprise of neutrophil, eosinophil, histiocytes, and also areas of necrosis in the background of hemorrhage. It was negative for any TB fungal growth and also negative for malignancy. So his final diagnosis that came out to be after culture reports came, was MMSA related brain abscess. So we started him on ceftriaxone, and after 2 doses, his conscious level improved from GCS 7 to 14, and he's still admitted with us and is improving.
Thank you very much, Dr. Sana, for excellent case presentation, and I'm also thankful to Dr. Shahab. Actually, this time we decided that we must involve our radiologists, because I think this is a great learning opportunity for all of us, because there are sometimes subtle things which we need to discuss among ourselves, because we have to differentiate between malignancy and infection and all that. So for ID fellows, I thought this would be a good opportunity to learn as well. Secondly, I'm also grateful to my all department at the hospital, because, you know, especially in HIV positive patients, it's very, very difficult to get a tissue diagnosis. And by knowing that this patient is HIV positive, most of the doctors, they are reluctant to do, especially to perform a brain biopsy. So our neurosurgical department is kind enough to perform all the aspirations and biopsies for us, even in difficult cases. That made it possible for us to make a possible diagnosis. And you know that after going through all these cases, I must say that all of them were having very close differentials, and it's very difficult without a tissue diagnosis and culture. It's very hard to say that this patient is having any kind of specific kind of infection, because you have already seen that there is a variety of cases, bacterial, fungal, viral. There is a huge variety of infections among HIV positive patients. We were having a lot of cases even in the absence of HIV, but we selected this topic for this because I think there was a lot of effort put in for these kind of cases. And one thing which I would like to mention over here, that as you have already seen, that majority of the cases which we presented were having low CD4 count. It was less than 100. And we could not find any typical correlation between CD4 count and the appearance of any infection. At a very low CD4 count, we were able to have bacterial infection. At the same count, fungal infection was there. So we could not find any typical or classical risk factors despite having low CD4 count, other than that why this patient developed fungal infection and why this patient is more prone to have a viral infection. And first case was of a tuberculous brain abscess, and he was having a CD4 count of 89. We can say that TB can occur at any CD4 count because it's very endemic disease everywhere. The second case was also having a very low CD4 count, and that was a lesion which turned out to be Aspergillus nudulans. We selected this case because Aspergillus fumigatus and Niger and other are very common, and they are environmental fungi, but nudulans is very, very rare. We could not find much of the case reports on that. But the characteristic thing about nudulans is that it is basically used for industry for, extracting enzymes, and it is also used in food industry. Other than that, this is not a common infection to be present, and there were only few case reports, as Dr. Sana already mentioned, and there were 2 in immunocompromised patients, and those patients who were having neutrophilic defects, they were more prone to have it. But brain abscesses were very rare. Lung diseases were very common. There were many cases they were found to have, fungal infection in their lungs. But brain abscess is very rare. But how come this patient acquired this infection? And CD4 count was 34. He belonged to Rawalpindi, and there was no specific risk factor for having this infection. But it was, something interesting to be shared, that we must have high index of suspicion for having fungal infections among HIV positive patients. Previously, we never had it because the reason was that we never happened to have a chance to, get brain biopsies and cultures and all that. But with more cooperation from the departments and microbiology, we are able to identify such cases. Third case was a very atypical case of PML iris, because initially the lesion were so deep and they were involving the white matter. And why we called it as a PML iris, because later on it involved the gray matter as well, and white matter was also, involved. It was very, very atypical case, as Dr. Shahab has already very beautifully mentioned, that how the disease spread from one area to involving the whole of the brain. And, it was not typical of PML, but since we were, not very much sure about the diagnosis initially, and there were so many issues regarding biopsy and tissue diagnosis and cultures and all that. And, many viral PCRs are also needed, which need a lot of cost involvement and all that. So initially we tried to treat him on the basis of a few investigations which were available, like his toxo IgG was also positive, and his serum syphilitic test hote hain, they were all, positive. And after that, we also thought that probably it may be TB, it may not be TB. So for some part of the treatment, we also started him on ATT, but he could not tolerate it. So we were in a desperate, phase to know that what is the actual diagnosis. And ultimately, we desperately sent his HIV viral load as well in the brain tissue as well. And it's very hard to differentiate between these two things, and we still don't know. But since the JC virus copies were in millions and millions, they are so high that it was most likely a case of JC virus, and it presented with iris. And for the iris management, literature shows that we can treat these cases with monthly pulse therapy of steroids, and we can also try metazapine, which was a desperate effort. So this was quite an interesting case to be shared. And the last case was of MSSA brain abscess. And here again, we were struck that what is the source of this bacterial brain abscess? We could not find anything on, echocardiography, but there was a large apical clot in left ventricle. And we were just assuming that probably it was a focus of infection, and probably there was some bacterial seedling on that clot. And there were some septic emboli which went to the brain in this particular patient. Since we do not have much of the treatment choices available for brain abscesses, especially, other than that, we drain it completely and then we treat it. Otherwise, we don't have much of the choices for treatment. So since these are all various varied presentations of brain abscesses in the background of HIV, I think it must have been a good learning opportunity for all of you. And if there are any questions, you can ask from my team and from myself. So the take-home message for our today's CPC is basically tissue is a real issue. So getting a tissue biopsy is a real challenge. And I must say that our ID fellows, they work hard day and night to engage various departments to get a final diagnosis. So if there are any questions, you are most welcome, or you can type in chat box as well.
Thank you for the participation. If there's any question, you can type in the chat box. We can share the recording.
It was a case of tubercular brain.
Yes, it was a case of tuberculosis. 89. It was 89.
What is the next one? You can type any questions in the chat box, please. I hope you enjoyed today's ID CPC. This was the first ID CPC from PIMS. Thank you very much for the full participation, and I'm really grateful to you all. So if there are no questions, we can stop here.
Thank you.
Thank
so
you.
much.